welcome to the Health and Adult Social Care Committee meeting. My name is Dan Work. I'm the Council's Overview and Scrutiny Officer. As this committee doesn't yet have a chair, I'm standing in the chair to run the election for a chair to the committee. Not on the agenda as well is a requirement for us to elect a deputy chair as well. I just wanted to ask, are you happy for me to run both elections, or would you prefer whoever you nominate the chair to run the vice chair? Are you happy with the first option? Okay, marvellous. Okay then, first item of business. Before I start then, I just need to inform you that this meeting is being live streamed and recorded. So, on to business. First of all, do we have any nominations for chair of this committee, please?
Can I nominate Councillor Steve Chalmers?
Yes, marvellous. That's seconded?
Second.
Okay, seconded by Councillor Dan Thomas. Any other, please?
Could I nominate Councillor Heather Kidd?
Okay, we have a nomination for Heather Kidd. Can anyone second that, please?
I can second that.
Marvellous. Seconded by Councillor Kate Halliday. So we have two candidates for the chair, Councillor Steve Chalmers and Councillor Heather Kidd. I'll take them in order, please. Could I have votes, please, for Councillor Steve Chalmers? 1, 2, 3, 4, 5. I count 5 votes for that. And could I have votes, please, for Councillor Heather Kidd? 1, 2, 3. Councillor Steve Chalmers is duly elected chair of this committee. Could I have any nominations, please, for deputy chair for this committee? Councillor Chalmers?
Yeah, I nominate Councillor Dan Thomas.
Okay, Councillor Dan Thomas has the nomination. Councillor Huffer?
I nominate Councillor Heather Kidd.
And Councillor Heather Kidd is also nominated. Okay, so I have two nominations for this, Councillor Dan Thomas and Councillor Heather Kidd. I'll again take them in order. Could I have votes, please, for Councillor Dan Thomas? That's 6 for, and for Councillor Kidd. 1, 2, 3. Councillor Dan Thomas is duly elected deputy chair of the committee. I will now hand over the chair to Councillor Chalmers.
Thank you and good morning, everybody. Item 2 is apologies for absence.
We've received apologies from Councillor Chris Schofield, who is being substituted by Councillor Roy Aldcraft.
Thank you. And item 3 is disclosable pecuniary interests. If there are any, please put your hand up.
Chair, just for noting that I actually work at a GP practice in Ludlow. I don't, not particularly pecuniary interest, but it's just for noting.
Okay, thank you. Moving on, item 4, minutes of the meeting held on the 13th of September. They were circulated after the agenda. Is everybody who was at the meeting happy that they are a true record so they can be signed up? Yeah? Yeah, okay. We just all have a vote and confirm you're happy with that, please. Yeah, thank you. Right, on to the main, what looks like the main topic of the agenda. Being my first meeting of the Health Scrutiny, never mind as chair, it came as a bit of a shock on Friday when I heard about all this, but it's obviously a very sensitive subject, especially in the south of the county. There's obviously a lot of interest in the current closure of Bishop's Castle Hospital from both members of the committee and the public. And indeed, you will have seen a large number of questions that have come into the council in the last few days. It's clear to me that we do need to scrutinise this decision and find out exactly what's going on and what the plans are going forward. But what I don't want is to be here for 2 hours answering very similar questions on the same theme. So what I've asked officers to do is to bring a meeting in early January to allow them some time to explore what is going on the ground locally, and then we can come back and scrutinise it in more detail once that information has been gathered. And that's likely to be the first or second week of January. The end of January is too late in my eyes, so we've asked to bring it forward. Having looked through the questions, there is obviously a common thread, and there was a lot of duplication of questions within the total amount which has been received. So I think if it's okay with committee, I would like to explore those common themes, and we've asked the Community Trust representative, Chief Executive Patricia Davis, who's online with us today, just to provide a brief summary to the current situation in Bishop's Castle Hospital, what the next steps are, and confirm the future engagement with this committee, including attendance at that meeting in January. Would members of the committee be happy with that approach rather than go through repetitive questions verbatim?
I'm only going to be happy with that if we can actually ask proper questions, because there are some really pertinent ones that we need to ask now, especially as we're looking at winter pressures and beds this afternoon at Joint HOSC. So there are some really important questions we need to cover, and Bishop's Castle has closed 10 beds at present, and I know my colleague from Bishop's Castle would like to raise those as well, so I would hope that you will take the local member for Bishop's Castle as well, please. Yeah,
I've got no problem with that. The purpose of the committee is to explore what's going on, and it makes sense to get the important questions. But I don't want to be here in 2 hours' time still answering questions, so there will be a time limit on it. But as long as we get to the bottom of the issues. So I'm in your hands, members. Do you want to raise questions now, or would you like me to go up to Patricia and find out exactly what their response is?
Can we have a presentation first, and then we can ask questions resulting from?
Absolutely fine. So I don't know who we are online.
Patricia's online.
Yeah.
Chair, can I just ask that everybody uses their mic, and then we can all hear what's happening?
Yeah, thank you, Roy. So can we pass over to Patricia to give us an update, please? Struggling to see the screen now.
Yes, thank you very much, Chair, and thank you for inviting me here today. And I've brought some colleagues with me in terms of the operational stuff if there are more detailed questions. So Angie Wallace, who is our Chief Operating Officer, and also Claire Hobbs, who is the Director of Nursing and Quality for the Trust. So just to give you a brief outline of the position. So we as a trust board took the decision to temporarily close, and that is an important point to make. This is a temporary closure of Bishop's Castle, which took effect from the 1st of November. So we're 22 days into that closure. This was taken on safety grounds because we found it untenable and difficult to staff the unit on a 24-hour rota basis. This is despite making every endeavour over previous months where it was highlighted that there are staffing issues within Bishop's Castle, and indeed we're no different to the rest of health and social care across Shropshire, and indeed the rest of the nation, around staffing crisis and workforce crisis, but it's particularly acute within rural communities and community hospitals. So we had for a number of months through our Quality and Safety Committee within the Trust been discussing the Bishop's Castle staffing issues in particular, and had put in with the staff from Bishop's Castle a number of mitigating actions to try and provide a safe and effective and sustainable rota, which we have not been able to do, and that became particularly acute over the few weeks leading up to the difficult decision to close. This included trying to create as flexible rotas as we possibly could, and also looking at the deployment and redeployment of more senior staff from other local services that unfortunately put incredible pressure on those services as well. And so, as I say, in the last few weeks, we were running pretty much on 100% agency for qualified staff, which is completely unsafe and untenable. Hence why we made the decision to temporarily close whilst we look at the staffing structure in the round. So that was this sort of the build up to the decision, and the reason why the decision was taken quickly in order to ensure patient safety was paramount. And one of the reasons why we were unable to sort of fully engage both with this HOSC and indeed with local residents as well. But going forward, we will make every endeavour, appropriate endeavour, with our commissioners, and Claire Parker, the Director of Partnerships from the Clinical Commissioning Group, is here today to give that assurance of engaging with local members of the public across Bishop's Castle and South Staffordshire. Sorry, that's a slip. South Shropshire and the wider area. So that was the decision in terms of taking that speedy decision, as I say, from a temporary point of view. We are also looking at the moment a wider recruitment, not just within our trust, but also across the system with the STP and with other providers to try and make these jobs as attractive as possible. We're running active campaigns for Bishop's Castle and the wider South Shropshire area. And we've just engaged in a wide campaign with the STP in terms of nurse recruitment in particular, but recruitment across the board in terms of clinical staff and non-qualified staff as well. So that's where we are in relation to that decision to close. And I'm quite happy to pass over to Angie and Claire to give some more detail in relation to that clinical decision. Claire, going to you first.
Yeah, so just from my perspective, from quality, safety and obviously clinical cover for that area, certainly what I've heard and what I understand now is we reached a position where we were absolutely untenable in terms of being able to keep our patients and actually our staff safe. So over a period of months, I think the position worsened to a point where it was just not acceptable actually to allow our substantive staff to try and continue doing what they were doing. So as a few examples for you, staff coming in early, staff staying late, staff sleeping overnight on site because they were so concerned about the levels of staffing and the skill mix that we had within that area. I had a nurse that worked a 12-hour day shift, felt she couldn't leave the site, slept on site overnight after doing part of the night shift, and then had to do the 12-hour day shift the following day. So never went home to her family for over 2 days. So you can see the position that our staff were working in to try and maintain safety in that particular area. What we also now know is that bank staff were choosing not to work at Bishop's Castle because it was so hard, because they were concerned about safety. They were choosing not to go and work there. And also agency, just generally anyway, is very difficult to try and bring agency staff into that area. But also what I know from working with colleagues in Shrewsbury and Telford Hospital is that due to the COVID pandemic, agency is very, very difficult to try and maintain anyway, because people are choosing to work closer to their home because they can, because there is so much agency out there due to the workforce at the minute. So what we know, the evidence base will tell you from a safer staffing perspective for nursing, that where you've got high levels of agency and temporary staff who don't know your areas, they don't know your policies and procedures, that is a huge clinical risk for us. It increases patient mortality, it reduces quality, it reduces safety, and it absolutely came to the point where we just could not expect our staff to continue to work how they were working. And clearly they tried to do it for several months before, but it shows in the sickness levels. So if you've got sickness levels of between 8 and 14%, our staff were getting tired. And actually when the decision was made, there was absolute relief from our staff that it had been recognised, because they knew themselves that they couldn't continue doing this anymore.
Thank you, Claire. Angie, do you want to add anything at all from an operational perspective?
No, I think Claire's covered it very well. Thank you, Patricia. The only thing I can add is that I fully support Claire from a clinical perspective. Operational delivery is very, very difficult because of those safety things that Claire has just outlined.
Thank you. And I think one of the questions from the floor earlier on was how does this impact on the overall bed capacity supporting SAF? And certainly our commissioners have been very supportive of the decision, but have also commissioned and recommissioned another 17 beds across the system. So in actual fact, the total number of beds at Bishop's Castle have been re-provided elsewhere within the system. And Claire Parker, well, I don't know whether you want to sort of make a comment around that.
Yeah, I mean, again, from a CCG Commissioner perspective, we would absolutely support quality and safety first, support the Community Trust in the engagement process going forward about what the future is, highlight the issues that we've got around recruitment. It's not just actually a nursing workforce, it's in allied health professionals and medical workforce as well. We do need to recognise that. And then just to state also to the committee that we have, as have the local authority, actually recommissioned a number of beds, including the designated settings and some further beds. And just again to say, we can have extra beds, but we do need that safe staffing to cover those beds and make sure that those patients are safe. So we're working very closely with the trust to enable that to go forward.
I think the sort of final point really is also the commissioners have increased investment in local community services, both in terms of the services we provide, but also the local authority services in terms of rapid response teams and the integrated discharge team to actively support, well, in first instance, to actively support the prevention of unnecessary admission to acute hospitals, so home first, keeping people at home, but also working with the acute trust to support speedy, safe discharges and swift discharges that re-able people back in to their home community. So home first, as we know from an evidence base, is far better for the patient. So commissioners have also, as I say, it's £750,000 funding for the rapid response and community services to keep people safe and well at home.
Okay, thank you for that. I think we'll take some questions from the floor for you, as long as we're across a common theme. And I can see Heather growling at me here, so she must have a list of questions already. Do you want to lead off, Heather?
I do, but I really don't want to step on the member for Bishop's Castle's toes. I am fascinated to hear how widely you've advertised, and I do understand this is a national issue, but not once did you engage with us across South West Shropshire, where we cover 200 square miles. Not once have you talked about looking for, if you want to bring people into the county and if you want actually to have people working in our rural areas, the housing issue is phenomenally difficult. And to tell me you've had no request for it is probably because you have never offered it. The issue here is that actually in Bishop's Castle, to buy a house, you have to borrow around 12 plus times the average wage to buy a house. So you don't get many staff wanting to come to Bishop's Castle. So engagement with the local members, all three of us, would have been really good. Being able to share your adverts for staff would have been really good because we have a very wide reach. And actually, the staffing issues can be improved tremendously, actually, if we can encourage people to come to Shropshire. I've sat on tubes in London on my way to the LGA, where you see Dorset and all sorts of places actually advertising for staff. We do not do that. So I reject your answer to my question about housing. I do want you to work heavily with local members. I do want you to work really well with Shropshire Council for key worker housing. the real problem in a rural area, and I want to know how you're going to take that forward, by the way. Secondly, if you look at 200 square miles of South West Shropshire, which is heavily the elderly, to have patients shoved into beds all over the place is particularly difficult for everybody, because there is public transport is appalling, and access, as we know, to our loved ones is really important for them to get well. Access is poor and for many miles. If we have to travel if I have to go to Ludlow, it takes 45 minutes. If I need to go to Whitchurch, it takes well over an hour. So there is a whole issue around impact studies to get people well. And yes, you will tell me you've got care in the community, you've got the package back into Stonehouse and Bishop's Castle for that care, which was a really good project that was taken forward when the floor was taken up in the hospital. You never carried on with that and the end of life care and that fantastic scheme that actually was brought forward, it was stopped. Then you moved, and I have staff living in my division who were told, one, they were going to be working out of Ludlow, and two, they were going to be working out of Craven Arms, and then suddenly they were put back. So there are all sorts of mixed messages about what's going on. And then just listening to you, dears, now, it appeared you were going to be consulting on not having any beds in Bishop's Castle, which will be a real impact on rural communities. So I would like some reassurance about that, and I think we need to have some real detail when we come to scrutiny in the beginning of January, because the winter pressures issue, which will be raised at Joint Host this afternoon, is fundamental for us. And when we get snow and nobody can get out. So a number of issues there around those and how we can improve this and keep the services in Bishop's Castle.
Okay. Would you like to respond to that now before we?
Yes, thank you. Yeah, so in terms of the housing issue, I certainly welcome every opportunity to work with you on supporting getting accessible housing, including rented accommodation and so on for our members of staff and the wider health and social care community within Bishop's Castle in South Shropshire. And that's something that I would want to be working locally with yourselves as members, but also officers around that. So thank you for that offer, and something that we will be sort of taking up in terms of that offer. In terms of communication, I completely agree with you. I'm from a woman from Wolverhampton. I worked in Shropshire for many years before moving down south, and yes, you frequently get adverts for working in other parts of the country in central London, and something that we would like to, as an organisation, be working with the wider Shropshire, Telford and Wrekin STP on comms to get for all of us across all of our health and social care services the best adverts out to people as in wider communities to come and work in Shropshire. It's a beautiful place to live. It's not the cheapest place to live, so again that engagement with the housing department I think is going to be fundamental in terms of what we can offer in terms of key workers, clinically from a health perspective, but also education and wider public sector services. I think is a really good idea. You talked about the community pilot that was in place before my time, actually, when the Bishop's Castle closed for the floor to be replaced, and it was, I understand, a very successful pilot where there was local surveys done with both clinicians, staff and indeed patients that sought it to be successful, and that's something that we want to reintroduce, is something that we are reintroducing with the staff at the moment and build on, because clearly that was successful, and it shouldn't be sort of an either or in terms of providing services to patients. So that's something that we're very much focused on in terms of building that, and the staff themselves and the local GP surgery have some really good ideas in terms of how not only to reintroduce that scheme of work, but build on it in terms of providing, for example, IV antibiotics in the community so that patients don't have to go to hospital to receive those, as an example. So that is something that we're really keen to really focus on and build. I've forgotten the last key point that you made, but I think it was mainly around the sort of housing and the recruitment element, and absolutely take that on board in terms of any support that members can provide.
I think that my big question here is, why didn't you think about this before? And actually, if this is happening in Bishop's Castle, is it going to happen to our other community hospitals? Because it could well do. They could all be at risk at this rate, because they all will not be safe. And I am still concerned, and I really, really would like to see the project come back and the end-of-life care being rolled out from the hospital. But I do not want to see those beds going, because I can remember my son-in-law's grandfather having to be put in a bed in Ludlow, because at that point we didn't have beds in Bishop's Castle. And I have a lady in Marton who's having to travel all the way to Whitchurch at the present time. Well, it's not a lady actually, it's a father, a son rather, having to visit his father in Whitchurch, which is over an hour. So there will always be people who need to be in beds, and the accessibility issue for rural areas and our rural community is vital, and that was my last point.
And I mean, you're quite right, it's trying to provide local services for local people, and that's something that we are completely committed to doing. Just to note, in terms of capacity and residency within our community hospitals, if you take Bishop's Castle as an example, when we sort of closed the unit, out of the 12 patients that were in the unit at the time, one patient was resident at Bishop's Castle. The rest were non-residents of Bishop's Castle. In fact, one was from Paris and 6 were from the Telford and Wrekin area, and the others were other Shropshire. So I think that's important to note, and sort of looking at occupancy over the last 2 to 3 years, and remembering that last year in particular was a and this year indeed is a strange time with COVID, of course, where we've had to move patients around different areas. So, but if you look at the sort of occupancy over the last 3 years, 85% of those occupying Bishop's Castle have been non-Bishop's Castle residents, and I think that's an important point to sort of note.
Tracy.
Thank you, Chair. For me, this is a little bit of a case of deja vu. We've been here before with Ludlow Hospital. We were told 4 years ago there'd be a temporary closure of beds due to safety issues and lack of staff. These wards and beds have never reopened. That was 4 years ago. That was despite a huge public campaign and consultation program. They've never ever reopened those beds. The same with maternity services. We were told it was a temporary closure of maternity services. Maternity has never ever reopened in Ludlow, and in fact now the building is up for sale. My fear is that this is going to happen to Bishop's Castle. We've never ever reopened those beds in Ludlow. I was told 2 weeks ago by a member of staff at Ludlow that some beds, they wanted to reopen some of the wards, but there was not enough staff. Bishop's Castle and Ludlow are linked. Staff work from both these sites. Please promise me that Bishop's Castle is not going to be in the same scenario as Ludlow Hospital. When the beds were closed, they've never ever reopened, and we were promised it was a temporary closure, and we fought and campaigned. Jill George, who's here today, fought a very vigorous campaign to keep those beds open, and they've never ever been reopened. And at the moment, I just have this sinking feeling this is what's going to happen to Bishop's Castle. This is the beginning of the end. In Bishop's Castle, these beds will never reopen. Please, can we have some reassurance for Ludlow and Bishop's Castle, because we need these community hospitals. I am sick and tired of having residents, patients, because I worked at GP practice, sent all over the county when they're released from the acute hospitals for rehabilitation. Some have been sent 40, 50 miles from home. It's not acceptable. These community hospitals are the bedrock of the sector. They prop up the acute hospitals. Please do not let us go down the road as Ludlow was, when these beds never reopen again. Thank you.
Want to respond to that one?
Thank you, Chair. So the number of beds at Ludlow Hospital is 25, and those are fully opened, and those are the beds that have been opened and available within Ludlow since I've been here since April. There were 12 of those beds closed for 12 weeks recently to do some essential maintenance, but those beds are now fully open, so there are 25 beds. In terms of some of the other services, just sort of reminding of Ludlow, we provide services from the Ludlow site, so do other providers within the Shropshire, Telford and Wrekin area. So we don't provide all of the services that are within there. So if you take, for example, sort of renal dialysis, which is provided by SAF, and other sort of outpatient clinics which are provided by SAF. Some services are provided by Midlands Partnership Foundation Trust, for example. So it's not a single provider hospital. So some of those services that you referred to have actually been provided by other organisations across STW and wider Staffordshire area. But the beds within Ludlow, the 25 beds and the MRU, which we run as a community trust, are, and we run a few sort of outpatient clinics as well, mainly related to physiotherapy and so on. But the majority of outpatients at Ludlow are run by either SAF or other acute providers. But those beds, those 25 beds, are fully open at Ludlow.
Yeah, can we stick to Bishop Castle or not? I know the other things.
No, it's just one. Yeah, it will be linked. And I totally appreciate you've only been in the post since April and 25 beds, but 4 years ago we had 47 beds, and previous to that we had 3 fully operational wards. We were closed from 47 beds to 25 beds. You're quite right, there's 25 beds now. And we were told at the time that those 47 beds, they would be reopened to full capacity. They've never been reopened. 25 beds in a hospital that has 3 fully working operational wards is just not, well, I can't even get my head around it. So yeah, you're quite right. Since you have been in post, it's 25 beds, but previous to that it was 47. Thank you.
Go on, Kate.
Yeah, my question is about, sounds like there were problems for several months before this decision was made. What did you do in terms of trying to work with partners, including this committee and Shropshire Council, who can actually, health and social care are very clearly linked. We've seen this with the issues with the hospitals and ambulances, and the fact that, there's been issues with social care. You're painting a picture of kind of making decisions in isolation. So what did you do to actually try and reach out to other people to discuss these problems? So it sounds like there was a run-in, and I mean, this is just a comment. It is very difficult to get this views as members of this committee, but also as patients and residents living in local areas via the press. So I'm pleased to hear that you're looking to improve communication, and I think this committee will be looking for you to do that if there are problems with other community services and not for us to hear by the press. But just linked to my kind of overall question, you mentioned the rapid response services you've put in place. Did you try that before the closure announcement, temporary closure announcement? And also, you've mentioned commissioners. Which commissioners are commissioning those services?
So yes, so sort of answering the sort of last question sort of first, really, around the rapid response service. Yes, the rapid response service integrated care discharge team have been in place. It was expanded last winter as part of the Winter Pressure Fund, and it's something that we've done jointly in Shropshire with Shropshire Council, and what we both put together was a business case back in May, June for an expansion of those services, rapid response services. So rapid response has been in place for several months prior to the decision being taken, and has been hugely successful in terms of providing home, and to the point that commissioners have expanded funding for that service so that we can ratchet that up again through the course of this winter. So it's not something that was taken as a decision after the event, but we've been trialling that before as well. As I say, you know, the evidence, there's very clear clinical evidence. I'm a nurse by background. I'm a district nurse. I started my nursing community nursing career actually in Shropshire Community and Mental Health Trust, as it was back in the day, and I'm still clinically registered and still practice. So, you know, from a clinical evidence-based point of view of patients, getting them home and re-abling them home at home is the best form of rehabilitation. But there are patients that do need a bed base where they need more enhanced nursing and medical supervision, and that's what we use our community hospitals for. So we tried a number, as I said in the introduction, a number of different. I mean, I think in hindsight, we should have taken the decision to temporarily close earlier. Actually, I think we tried to put in place, and indeed the staff themselves, because of their loyalty to the unit and to the local patients, the ward manager. Amanda is born and bred Bishop's Castle, and very proud of Bishop's Castle. She went there first as a care assistant and then went off, did a training, came back. And it's a sense of pride for her that she became the ward manager of that unit. So it was not a light decision for her. Her and her team tried every possible mechanism of flexible rotas, of flexible shift patterns. You mentioned Ludlow and our links with Ludlow in particular, which is strong in terms of that staffing, with Ludlow staff providing remote supervision and support to the unit, which of course put pressure on then the Ludlow team. So they provided every endeavour to look at their rotas in the most flexible way. I think your point around could we have reached out earlier, I think possibly. As I say, I think we tried to put in every mitigating, because this was it's not something that we wanted to take a decision that we taken lightly. And I think you know, running at, you know, as Claire was saying, running at 100% agency with the ward manager and others sleeping overnight because they felt so committed, you know, that was they were trying to keep the show on the road. Then that's not something that we could continue with. But working locally with the staff and with yourselves going forward and local residents, so that we can attract more staff to that area, but also think a little bit more laterally about how we provide services as an outreach into the community as well, I think is a way that we want to sort of move forward. But as I say, in hindsight, I think possibly we should have taken the decision to close earlier. Yeah, as I say, we just, you know, from my own clinical perspective, and listening to the staff in that area, we needed to support. It was for their safety as well as the safety of patients.
Okay, thank you. I'm going to go to the local member, Councillor Ruth Houghton. Is there anything you'd like to add in, Ruth?
Yes, please, Chair, if I may. I've listened to the questions and the answers and the responses given. And representing the community, there was a huge shock when this was announced. There was no notice, no prior warning at all. And you know, you mentioned in hindsight it should have been closed earlier, but I would challenge and say in hindsight, perhaps the pressures and the difficulties that the hospital were experiencing on recruitment should have been shared earlier, both with this committee and locally. And Councillor Kidd is absolutely correct. You know, if we are involved in the southwest of the county as local members, we have very wide communication networks and regularly send out bulletins to our residents at least every 10 days to over 2,000 people between us. And that network does promote employment as well, and employment opportunities. Having listened to the responses, I'm interested in particular to know where the new 17 beds are that have been re-provided. Where are they in those designated settings? there isn't a nursing home in Bishop's Castle. The nearest one is St Nicholas in Churchstoke, which is in Powys. The others are in Church Stretton or Ludlow, all of which have very limited public transport. In fact, it's not possible to get to Church Stretton on public transport or Churchstoke for anyone who is visiting. And services to Ludlow via public transport are exceptionally limited, probably 2 or 3 times a week. So there are extreme difficulties. There is a huge amount of community support for the hospital. There always has been. It's been part of the local community for over 50 years, and that hasn't waned at all. What I'd particularly like to know is, or have sight of, is the equality impact assessment. Is it in the public domain? Having looked on the website, I've either not found it or it's not there. But I'd particularly like to see that and how the mitigations are listed for rurality, age, disability, and particularly for carers. This morning's debate has not once mentioned family carers, who are those people who will be left at home, managing people, supporting their families and loved ones overnight, over 24-hour periods. And I really think that's a large gap that needs to be addressed promptly. I just want to share with the committee as well that from Bishop's Castle to the Royal Shrewsbury Hospital is 22 miles. There is no public transport on a Sunday when people would like to visit. It takes about 40 to 45 minutes. And to Princess Royal, it's nearly 37 miles and takes just under an hour. And that's not on a fast motorway or A5 or A road. They are on rural roads, and those mileages and times are from the hospital. Bearing in mind that the hospital in Bishop's Castle serves a much wider, more rural community, you can easily increase that mileage and that travelling time. So my plea, as Councillor Huffer and Councillor Kidd have made, is that Bishop's Castle Hospital is reopened, that we are fully engaged and consulted, and that we look forward with the community and help people to see Bishop's Castle Community Hospital as a valued career. The staff that are there are excellent. We just need to make sure that vacancies are shared locally and people are encouraged and supported to apply. Thank you.
Thank you. Back to the Trust.
I think that's, I'll take on board sort of Councillor Houghton's statement, really. I don't think I've got anything else to add or respond on that question.
Okay. Ruth, you want to come back?
If I may, Chair, could we have sight of the equality impact assessment, please?
Yes, I think absolutely that's something we can share.
Okay, we'll get that circulated then. Just before we sort of wrap this up, I see Simon Jones, portfolio holder, online. Simon, is there anything you want to comment on?
No, I don't think there is anything more that I can sort of comment on at the moment, but certainly we will be working closely with the Community Health Trust on this issue. Yep.
Okay. I don't know who's first there. We'll go with Ruth first and then David.
One of the questions I did have in my statement is where the additional 17 beds have been re-provided.
So, Claire Parker, you may want to sort of comment on that. You have the detail.
I do. I don't have all the detail of the geographical locations, but they're across the system. They're not necessarily in South Shropshire. We're in a really tight with community beds, so we just kind of have to take the provision. But we can get that information and then we can pass it on to the committee if that would be helpful in more detail. So all I've got at the moment is we've got 5 designated setting beds, but I don't have the locations. I can get those. We have 2 at Lady Forester, and then we have 10 additional beds in Telford and Wrekin.
Great.
Okay. David, you just wanted to come in. David, voice from Health Watch.
Can I say I'm completely ignorant about the situation that's happening at Bishop's Castle, but I assume a lot's going to be investigated to find out exactly what's happening and what's going to happen. But I was just wondering, because I don't even know what your normal staff complement is. What is it? What vacancies have you got? What encouragement have you made so far? What progress have you made regarding recruitment? And you've had 3 weeks already to try and sort things out prior and you knew it was coming along. So can you just say very briefly, how far have you got in the progress of getting recruitment and where are they coming from? And what attractions are you giving people, in actual fact, to apply?
Okay, thank you. I'm not sure if you've heard that, but the question was, you know, what is the complement of staff at the hospital itself, and how far are you along the recruitment process, and is there any success so far?
So we've been running at a sort of a complement of, I mean, Claire will probably be able to give more detail, but our staffing, for qualified staffing, we're running at a sort of a 73% vacancy rate for band 5s, and which is the sort of sort of qualified staff nurse level, if you see it in that term. So we're running at a 73% vacancy rate, which isn't sustainable. Over the last 6 months, we've run over 9 campaigns for registered staff, registered clinical staff, with very little take up of, and our most recent campaign that we ran yielded no applications whatsoever. We've had slightly more success with healthcare support worker non-qualified recruitment, but even there, where we've made 5 substantive appointments, 2 have then subsequently moved on and left. So we are running continuous campaigns. We run them within a number of areas, and particularly on NHS jobs and through the nursing press. And then we sort of run them for a period of time and then close them so that we can collate all of the responses and then reopen the advert. As I say, the most recent advertisement has yielded no applications from qualified members of staff. We are fishing in a very tight pond across the whole of Shropshire. We're not the only ones that are finding it difficult to recruit qualified staff, and as I say, that becomes even more acute within significant rural areas, which is why we have sort of joined forces with other providers and staff to provide as much skill breadth as possible. So if we can provide rotation posts where people can keep up their acute clinical skills into SAF, for example, where we can provide people with opportunities of rotating in and out of the community. As I say, I come from a clinical nursing background and a community background, and used to sort of rotating in and out of community hospitals and into the community, where people can follow through and see their patients in the community as well. And often that can be quite attractive, where you can see the whole gamut and continuity of care across a patient group. So offering as much opportunity for people to develop their skill set as possible, and working across into other areas, like, for example, Ludlow, where there are more acute services within the community hospital, if you want to use those words, with an MIU being present and so on. So having that whole package of operating across the South Shropshire area for staff might make that, again, a little bit more attractive in terms of breadth of skill. We're working very closely with our education providers, so the University of Wolverhampton, the University of Chester, not only in terms of getting people off the conveyor belt once they're trained and into jobs, but also looking to grow our own. So we are engaged in a number of with our local education providers of nurse associates, for example, if we're looking specifically at nursing, where people can come in as a healthcare support worker and develop additional skills, and we put them through their training. We have one nurse associate with us at the moment who's about to qualify in the Bishop's Castle area, and she wants to stay within the community setting within Bishop's Castle, so that's great. Nurse apprenticeships is another example that we're engaged in. We're also working with, as I say, STW, Shropshire, Telford and Wrekin ICS, on a wider health and social care recruitment campaign, and we're also engaged along with our acute provider in international recruitment of qualified staff in particular. It's really important that with international recruitment though, you provide a very good support base in terms of bringing people in so that they have clear connections with other people from the international community that can provide them with the cultural support that they need. So there are a number of different initiatives that we're undertaking, both as an individual organisation in terms of the services that we provide, as well as with other organisations, including the local authorities, so that we can create attractive posts. But it is a challenge. It is a huge challenge, and I can't, you know, we can do all of that, but it is a huge challenge, and it is a huge challenge in the context of a national recruitment and workforce shortage issue, which needs to be recognised and noted.
Can I just finally comment? My concern from what you've been saying is that this temporary could be a hell of a long temporary, and I would hate to think it turns into a permanent situation where it's closed forever. Is there any possibility of that? Be honest about it. Is there any possibility of that?
I think, as I say, I can't underplay the challenge that we've got in terms of workforce, and it's not just my services; it's also the services across the system, and we've got to be realistic about that. I haven't got a magic nurse tree where I can pluck registered nurses from. I wish I could. We are, as I say, we are engaged in every opportunity to create registered clinical nurses and registered clinical staff, looking at different ways that people can expand their skills so that we can have peripatetic therapists and nurses that can work across a number of different skill bases and so on. But it takes time to train those individuals, and it's a challenge that we're all facing, and not just within the health service. You'll know yourselves that social care faces equally a very deep challenge, but it's how we work together to improve that situation across STW.
Okay, I've got 3 more questions, then we're going to draw it to a conclusion. So I've got Jill, and then Jeff, and finally Adam.
Thank you, Chair. 2 questions. There was a Community Trust Board meeting on the 7th of October, and the finance paper endorsed by the board took a decision to meet savings targets by slashing agency spend at community hospitals. So the first question is the closure of Bishop's Castle Hospital, announced to staff only a week later, is it a part of that wider policy of cutting agency spend at community hospitals? And of course, which other community hospitals might be affected by that? The second question is, there's very, very well established legislation, which of course you will be aware of, that places a statutory duty on the NHS to engage both the public and local authorities when considering making changes to service delivery. The only possible legitimate excuse for not having carried out that engagement would be an immediate and urgent safety issue. And yet what you've reported today is knowing of safety concerns, staffing issues building up over a period of many months. So why on earth did the Community Trust not follow that statutory duty to engage with patients, the public and the local authority? Thank you.
So I disagree, Jill, in that I think it was, and as I say, I'm a qualified nurse, still registered, still practicing, and Claire can give her kind of view as the Director of Nursing, but I think there was tremendous pressure and I think a real risk to patient safety and indeed safety to our staff, which is why the board made that decision. Despite the fact that we had been talking about staffing issues and had attempted to put in place a number of mitigations, it was right and proper that we explored those first. But certainly over the last few weeks before the decision was taken, running on 100% agency is not tenable nor safe, and it was not the decision that the board made to temporarily close Bishop's Castle was purely on safety grounds. It was not on financial grounds. And the paper you referred to in relation to looking at agency spend is in relation to some of the escalation areas that we have across our hospitals, and looking at that because, again, if you open escalation areas, there is clear evidence that you pose a greater risk in terms of patient safety, in terms of infection control and so on. And so the agency was based on looking at reducing our agency costs in terms of those escalation areas and keeping the escalation areas closed so that we could more substantively staff our main bed base and therefore be able to provide care to those patients and turn those patients around more effectively than opening up more and more bed capacity that we clearly just couldn't staff. So there is a clear link between agency use and greater harm to patients. But I'll hand over to Claire on that point.
Yeah, fully support what Patricia's just said. So yes, I think there were concerns raised months in advance, but those snowballed and actually reached a point that became untenable. I think one of the examples would be the fact that we started to delay admissions into the Bishop's Castle hospital beds, keeping patients longer in the acute setting because we didn't have the skill mix and the numbers to be able to bring those patients safely over. And I would also say that I believe Ludlow MIU was closed in order to repurpose those staff to support Bishop's Castle as well. So there were elements that were there and had been there for a while, but they were starting to build. And I would also say, in terms of your point around agency, that yes, that is absolutely incorrect. And if it was the fact that we were closing those beds based on saving agency, then we wouldn't have moved the 3 agency staff that we were using regularly over to Ludlow and still be paying them.
Okay, thank you. Councillor Elmer.
Thank you very much indeed. You've made it clear that this is not just a financial decision, but you've been paying agency staff quite a high percentage above the normal nurses rate, I'd imagine. Is it possible, because you're competing with the rest of the country for jobs, can you not offer any financial incentive to recruit staff? Could you not pay them 5% more as a bonus or whatever, just to get them to come and work here? I mean, that's bound to be saving money over the percentage cost of agency staff that are not reliable. It would be surely better to offer a fee, a finder's fee or whatever, to get staff and make sure that you're offering a better deal than any other trust. Is that possible?
Am I okay to come in there, Patricia? So I think we need to check with our HR director, but my understanding is, because we are part of a national pay system called Agenda for Change, that we have to stick to the rules of Agenda for Change, and so that is not possible. What I would say is there is probably some scope in us reviewing some incentives to come and join and work in our semi-rural and rural areas, and that is something that we've picked up with the work that we're doing with the wider integrated care system as well, trying to develop a model called the Shropshire nurse model to encourage people to want to come and work in this area. It is extremely difficult at the minute nationally, but I would say it's worse here at the moment for us because we are at the end of a motorway network. So nurses that you would try and encourage to come are passing big teaching hospitals, they're passing much bigger, larger community trusts on the way through. So unless they are actually living in our area, and it goes back to the point around what we can do to support housing, then it is extremely difficult for us, even with those incentives, but absolutely are exploring that with the ICS.
Okay, thank you. And finally, just to wrap up on the subject, Heather.
Thank you. I would hate you to go away not thinking that I don't understand the pressures. In fact, my daughter is a band 6 nurse in North Shropshire. So I absolutely understand the issues and so on. I think for me, the issue is the poor communication with local members and what we can offer you, that you didn't actually even think about that in the first place. I was going to raise the agency working issues, not on costs, but actually on being able to raise a band or whatever around that. But you've just answered that, but I would like to see all of these questions answered in writing, some of these really particular ones. But in the past, I've spent quite a lot of time trying to get bodies into the community college in Bishop's Castle, because many of the young people in Bishop's Castle are challenged with transport. It's a difficult place to get in and out of. And the very example that you gave of healthcare worker who's gone on to qualify or is about to qualify is exactly what we need to be encouraging in Bishop's Castle, because it is a lovely place to live and people want to live there and they want to stay there. Our young people want to stay there. So my big challenge to you is to involve us and to involve Reuben Thorley, who's the head teacher at the community college, so that you're getting in there before they leave school at the age of 16 and before they go on to other places, and that we keep them, because if we've learnt nothing else during this pandemic, the NHS is vital to us and it's a stable job. When everybody else was put on furlough in all sorts of different things, actually the NHS was there and working hard. It may have been very stressful, and was. My daughter's a high dependency nurse. But we actually need to work together, and I mean together, not you telling us, it's working together to make sure that we grow our own very locally. And South West Shropshire is not like Shrewsbury. It is not like Ludlow. It is very different because we are so dispersed. And my huge regret out of all of this is that you did not contact us, and we read it in the press, as Kate said. And I can understand why you would have told the MP, but even he knew about it, but we didn't on the ground, and we were barraged with comments because we are on the ground working. So there are lots of lessons to be learned. But I really want to see a work plan at the next scrutiny so that we know exactly how you're trying to recruit. I need to know how you're going to work with the local plan across Shropshire and the officers, because key workers are vital in the care sector as well as for the NHS, as you mentioned. I want to see some detail about how we're going to do that and how actually we're all going to be involved, because we're never going to solve this by just being the NHS or just being Shropshire Council.
Thank you, Heather. I don't think there was a question there.
There was. I want to see those to the next.
Yeah. I'm not going to ask you to comment on that because I think we're going to explore that at the next meeting in January. I think you've done well to extrapolate the challenges which you've got. There may be some challenges back in the room here, but you would expect that anyway. But I think we need to work with you closely over the coming weeks and months to make sure we get a long-term sustainable solution.
We do need some written answers to some of those questions in the room for Ruth and me, just so that we've got some of those things in writing. And this is all been recorded.
So yeah, I mean it's recorded anyway, so
they can answer.
Yeah, and we'll make sure that you get a written copy of everything that's been discussed in the room, so you've got something to work on. But I'm sure Daniel and the officers here are working on that already. But can I thank you for your time this morning, and yeah, we are going to continue interrogating you over the next couple of months and hopefully find that long-term solution. But thank you for now anyway.
And thank you. Can I just say thank you for your time as well? And yes, there's been some healthy challenge which I expected and would have expected, but also thank you to Heather and others in the room that have reached out and said work with us, and that's something that absolutely we want to take you up on. So some of the suggestions, Heather, I think it was Heather, suggested about sort of contacting the local school and getting heavily involved with the local school and so on, and growing your own. You're spot on. So if we can take you up and that kind of support as well, and a link, that would be truly appreciated. So we want to work with you, and I take your point that it would have been easier to sort of work with you beforehand to make that contact. So firstly, I want to apologise for that. It was a decision that we didn't take lightly. We needed to act, but absolutely want to work with you on the wider solution. So thank you for your time and your suggestion. Much appreciated.
Thank you. Okay, so hopefully we've explored that to a certain depth. It's been more valuable than having repetitive questions. So thank you. So we'll move on to item 7, which is the new direct payments policy. So we have a number of people on screen again to talk us through. I think Gary is the lead. Is that right?
So I think it's a combination of both myself and Carol and our two guest colleagues as well. That'll happily take you through this presentation.
Okay, over to you guys.
Okay, well, if it's okay with yourselves, I'm just going to drop out this to put the presentation on the screen, so bear with me. I'll do that now for you.
Morning, everybody. I think maybe if we started off by introducing ourselves. I'm Carol Crotsford and I'm one of the service managers in operations in adults. If we move to Katie.
I'm Katie Stone. I'm a service user in Shropshire, and I'm the chair of the Direct Payment Board.
Thank you. Beth, have you managed to join us?
Can you see me? I have my camera on my screen, but maybe not on yours.
Yeah, I can't see you, but I can certainly hear you.
Oh, excellent. I'm Beth McDowell and I manage my brother's direct payments, and I'm here as an expert by experience. Thank you.
Thank you, Beth. Gary?
Thank you. Yeah, I'm Gary Heap, Adult Social Care Operational Service Manager, and I'm operating the slides. So this is new territory for me, but we're gonna get through this.
Thank you. So we just wanted to say thank you very much for inviting us along this morning. What we've presented here, or what we're going to present, we will be sharing these slides. I know you haven't had them in advance, so we will share them after this. We also wanted to take it from a point of introducing what direct payments are, as well as the work that we've achieved and the work that's gone forward. So apologise to any of you who actually know a lot of this already. We decided to take it at the sort of this is what a direct payment is and move that forward. So thank you very much for the invitation to do this. So we're starting with the first slide, which is basically direct payments in Shropshire, and sharing with you almost towards the end of our journey, where we've come out with our philosophy and also the founding stone for the new policy that's been written and taken forward. So after a lot of work, which we will illustrate now, we've come up with with a direct payment, I can live the life I want. This is the message that we've received from the people that we're supporting. And the jigsaw pieces there very clearly illustrate that the direct payment process needed to be, and is now as a result of the work that's been completed in co-production, open and honest, flexible and creative, and clear and simple. So every single time we look at developing, writing, moving forward, setting up, we always question ourselves and challenge ourselves. Is what we're doing open and honest, flexible and creative, and clear and simple? So for those of you that may not be aware and may be sitting there thinking, what is a direct payment? Direct payments are payments from Shropshire Council, where following an assessment, a Care Act assessment, it's been identified that the person does have some eligible assessed needs, and that those eligible assessed needs are going to require a response. So a direct payment is a payment that's made, as it says, directly to the individual who's in need of the support that's been identified. There's a lot of conversations that are had with the individual or their nominated other or support system as to what could meet the needs that have been identified. Direct payments aren't just about buying in care, they're also about payments to provide other sorts of services, be that pieces of equipment that aren't provided from other sources. Could be laptops, it could be a swing in the garden, it could be a wide, I mean, it's as wide and as flexible as people are, because people aren't all, you don't tick 3 boxes and come up with an answer. So it's very, very much based on the conversation that's had with the individual as to, okay, these are your needs, we've agreed these are your eligible assessed needs. What sorts of things do you think we could put in place to meet those needs? We We would like to direct you to have a look at our new direct payment website. It's very new, it's on a soft launch, and there's certainly a video on there that gives a very clear sort of story as to what a direct payment is. We've decided not to show it at this particular moment because we're aware we haven't got huge amounts of time, but please do have a look at that link. Direct payments are the government's preferred mechanism for personalised care and support. That relates to one of the guidance paragraphs within the legislation, but it's also Shropshire's preferred mechanism. So we are very keen to promote, develop and support direct payments as our first option when we're looking at funded support or funded services for any individuals. They're better value, they give people more choice to live the life they want to live, and we're going to illustrate this with some examples now, and we believe it definitely improves their well-being. Gary, do you want to take over?
Certainly, I'll give Carol. Oh, can you hear me okay?
Yeah.
So we're in Shropshire, we've been supporting people since 1996 with direct payments. That's part of the original guidance that came out from government. I think there might be some examples we were doing it before that in Shropshire, but certainly since 96, we've been trying to provide them to the residents of Shropshire. But we kind of felt that it needed a complete review. We wanted to kind of look at a new approach around direct payments because they're rather not as creative and available as we'd like them to be, and some of the feedback we're receiving from the recipients. So it was an opportunity to kind of look at reviewing what we were doing. We've developed a new direct payment board, of which Katie mentioned here as the chair, and actively involved in that. We decided that we bring direct payments back in-house, as that they originally provided by or agencies, organisations, or supported by individuals outside the council. But we recently decided to bring it back in, and we now have 3 dedicated staff working in Shropshire Council around direct payments. That's supporting individuals, also providing advice, also supporting our staff in the setting up of direct payments. I think probably evidence that we're more committed to this approach now than we have been in trying to as Carol referred to, make it available, or first point of offer for the individual residents in Shropshire. For pretty much the reasons that were illustrated by Carol, in the way it's that the flexibility, the best value, the way it can be used, and the creative way it can be used, more interestingly. So who are we? Let's kind of introduce some of the people that form part of the direct payments support team. Hopefully you'll see individuals coming up in front of you. Just to give you an illustration of how many, these are experts by experience. These are staff within Shropshire Council and recipients of direct payments as well. Now we're going to just show you a short video with one of our direct payments leads, Chris Roberts. Now, I'm hoping this is going to work. Can you please tell me if you don't hear anything? You should hear some.
Hi, thanks, Roberts. Direct payments, and I'd like you to come with us back in time to the direct payment workshops held in 2019. Where did it all start? It started with a direct payment board and working with the Think Local, Act Personal TLAB. It was about rehumanising the system. 185 people attended the 2 direct payment development sessions. The sessions were introduced as an opportunity to rehumanise the system. The days were delivered jointly by experts by experience, adult services staff and TLAB. And their aim was to tell our story now. That is, for people using direct payments and staff supporting them. To reframe thinking about direct payments, and for those people to leave with a shift in mindset and feeling inspired. One of the greatest challenges in life is being yourself in a world that's trying to make you like everyone else. Why did people need to come together in the first place? It was clear that direct payments were not working well and could be improved. People told us they required employment support, training, and help recruiting and retaining personal assistants. Also, the service wasn't flexible enough to meet individual needs or support those people who didn't want to be an employer or wanted to purchase other services with personal budgets. Time to think. Clearly, we needed to rethink. So working together, the Direct Payment Board, which is made up of people who use direct payments and staff, pushed for these developmental sessions. We were supported by the national organisation, Think Local, Act Personal, but most importantly, the sessions were facilitated by experts by experience, the people who make use of services alongside staff. So, in a humorous way, this slide pretty much sums up where we were in 2019. The two paths were separate at the time. They've come much closer together. To the left, you can see a desired path, and that's user experience. And to the right, perhaps a path that Shropshire Council will have designed. Desired paths. Basically, they are the informal paths that people create around buildings, through parks, and across towns. They are the way that people actually prefer to use to move from A to B, rather than the route that has been designed for them. Why desired paths exist? It's done against the will of some authority that would have us go in some less convenient way. Anyone who designs or delivers services must work together and in partnership with people who understand it most. And that's why the workshops were created. All the work since has been about together, looking for ways to bring about change that is positive for people and the lives that they want to lead. Today is an opportunity to tell you what was said then and what has been done since.
Thank you.
I think, Beth, you're going to help us with this bit, aren't you?
Yes, I am. Yes. Hi, everyone. As I said before in the introduction, I manage my brother's direct payment, and so I'm classed as an expert by experience. I received an invite to attend the workshop, and I wasn't sure what to expect. We can keep clicking through the slides, the photos will just come up. The workshop started with a very brave lady who told the room full of people how her support plan hadn't changed in the last 27 years since the first time she was assessed. And I thought, wow, this fabulous lady has stuck her head above the parapet and it hasn't been shot off. This woman is telling it how it is, and she told her story and it aligned with mine. This is what gave me the courage to tell it how it was to the people on my table. I was on a table with a group of social care team, and it was a revelation for me to learn that if you received a direct payment, you didn't need to live in fear. The people in the meeting who worked for the council had previously been viewed, in my experience, as the enemy. I realised that we all had something in common. The reason we were all there is because we cared about people. The feedback from the people with experience of using the service was shocking for the attendees. It was raw, and it was heartfelt, and it was passionate, and it was desperate, and it was fueled by frustration. You can see the types of feedback that are coming up on the screen here. There's individual, simple, unrigid system, keep on challenging, help back to take control, encourage creativity, change, choice and control. Choice kept coming up, flexibility kept coming up, trust and being open. The sentiment for all of this workshop could be captured in the next request if we keep running through, which is rewrite everything. Next slide, please. We learned that the common themes of needing to be flexible and creative and straightforward and less rigid, with the feelings of the recipients of direct payments being accused of fraud or feeling like they were being accused of fraud when they weren't trusted to spend the money they'd been given wisely. And this compared to the responsibility the council workers had to prove that the money was being spent appropriately, but with attention in allowing budgets to be spent to meet the individual's needs. There were communication barriers that were noted. The people on my table in the workshop were shocked to hear what I had to say. that I had no idea what was going on in their world. There was a brick wall between us that nobody had seen before we had this conversation, but the conversation in the workshops allowed us to take the brick wall down brick by brick. Following the workshop with the photos was in October 2019, and I left my contact details, and I was invited to Amend the Gap workshop, which was a series of monthly workshops that took us up to May 2020. It was during the Mend the Gap workshops where, for the first time, I learned that we weren't being fraudulent and that the assignment of funds was all about eligible needs, which is why my brother was receiving the money. I learned what the eligibility criteria were, which was previously a complete unknown to me. Every assessment we had been going to was like going for a job interview and not knowing what the job was. We discussed the language used in assessments, saying helping with eating and drinking is much more easy to understand than maintaining adequate nutrition and hydration. The focus was on making not just little changes, but by using direct payments to be exciting, individual, and making real and radical changes to the way that direct payments were used, by having creative and flexible support planning that was part of the system. The things that had been lacking were flexibility in the system, choice for the individuals, and simplicity. Next slide, please. The Mend the Gap workshops, which worked up until May 2020, were great at identifying gaps between social workers, trainees, managers, and the people receiving the direct payments. And from these gaps, we formulated a series of task and finish groups, which were focused on different topics, using experts by experience like myself and Katie, social care staff and staff from the council finance department. The topics used to explore the gaps and the associated actions to remedy them were around coming up with a vision, which we saw before, using those words that we heard in the workshops, being flexible and creative, open and honest, clear and simple. We were rewriting the policies to make it more straightforward language, whilst still gaining approval from the council's legal team. We rewrote the letters that people receive from finance. We rewrote the templates for support plans. And all of these groups have closed their actions, apart from the recruitment and retention of personal assistance, which is an ongoing action. Thank you.
Thank you, Beth. So I think what we can share is that the impact of this learning together has had a significant impact on our whole direct payment process. So co-production is definitely key. We definitely wouldn't be anywhere near where we are now without the joint working together that we've developed. We have the new vision, we have a new policy, and we have an agreement. As Beth said, we've reviewed and renewed the letters so they have a more friendly approach. The welcome pack has been designed so people who now start with the direct payment receive a folder with information coming in so that they can actually use the folder themselves for the information that they need. There's a new guide to eligibility. What that means is we actually have a very simplified, easy approach to introduce people before they have their assessments as to what the eligibility is and how that works. It's a one-page sheet of paper literally that introduces assessment. The direct payment leads produce a regular newsletter. The new website, as I said earlier, is now up and running. It's very much at its early stages. It's in its sort of soft launch stage, but it's there. You can look at it, you can see it. We've had a We Did event with 2 weeks of learning for staff, which happened in March this year. So there were 2 weeks of learning and training coming together. We continue to work with the cultural change for all staff so that the message about direct payments is taken on board and we're all on message. We're all seeing that. We're all working towards the same aims. We have new training for current staff, and we've actually taken social work students into the direct payment team, so that we've, as well as looking at how we can support our current practitioners, we're also looking towards the future practitioners and newly qualified social workers. So a lot of work's being done, and we've already had an impact on university training, so that been back to local partners who support and train social workers of the future, and we've raised the need to actually have conversations about direct payments, what that means and why it is the first choice and should be the first choice for all practitioners.
Just draw your attention to the lovely Grace and holding one of those welcome packs, who's been actually helping us put the welcome packs together, which has been lovely as well.
As I said, everybody will receive these slides and the links into the direct payment website, so please do take a look.
Just to give an illustration of some of the ways direct payments have made a difference to people, there's a couple of examples here that receiving feedback. So asked if we buy a body pillow using direct payment, and the difference that made for that individual. And if you think about all the other things we probably explored, and just for her to buy a body pillow that enabled her to be more comfortable, not needing so much intervention, somebody's put, life has started to open up for me using direct payment, which is quite a strong statement to make, but that's obviously how it benefited her. And then we have Sarah, who's the mother of a young 18-month-old child who suffers from seizures, and used the direct payment to help employ a friend who had a lovely understanding of her particular needs, but was able to use that direct payment to actually employ a friend rather than somebody who may not have been as aware or understanding, was able to kind of access the community again safely with the support of a friend. So some lovely examples there. And Katie, hopefully you're going to give us a small insight into how direct payments have helped you or supported you and how you've come across them.
I was told that photo was going to be removed, so I apologise for how that still does look. So direct payments have made a humongous difference to me. I went from being completely able-bodied in beginning of 2011 to being disabled later on in the year. Direct payments have given me a life back. It's a different kind of life to how I imagined, but it's a life nonetheless. By having a PA rather than alongside a care agency, my PA's allowing me to go swimming, which is improving my physical and mental health. My walking, I'm able to start improving because I'm able to start going to physiotherapy, because I've got somebody who can drive me, whereas a care agency, they can come in and out, but they can't do anything additionally. And just having a PA, it's a different form of relationship. They become more of a friend. That side of things has made a huge difference to me, because I haven't been able to, the friends I had, I've kind of lost as time goes on. So having somebody that I am able to employ through my direct payment, who's become, whilst a professional, but also a friend at the same time, has made a humongous difference and improved my mental health, and therefore it's kind of worked off and improved finances in different ways within the NHS, CCGs, all the rest of it. So, you know, it's kind of been made a humongous difference in many different ways. Oh, I'm really sorry, I've had a brain dead moment. Carol, can you prompt at all? Or Gary, can you prompt?
Yeah, I mean, Katie, I think you could probably talk about some of the supports. You've joined us in many meetings, haven't you? You've taken part in many sort of new opportunities, which your PA has enabled you to do.
Yeah, sorry, thanks, Carol. So by being able to partake in the meetings that I've been able to do, it's given me a sense of who I am. As soon as I go into the meeting room, my disability is left at the door. I go into the meeting room and my voice is on par, if not more important, because my experience is needed as someone like Tanya Miles, as somebody who's, you know, who was like Lee Chapman, who, you know, the portfolio holders, someone like Carol, someone like Gary, because I've, you know, I've got that experience there, you know, my
yeah, your lived experience is really important, isn't it, Katie, for us all?
That's exactly it, you know, and it's, you know, that's what's being proved as vital and is what's making a difference to bringing the board on a daily basis.
You've certainly had a very valuable part to play in the development of the policy and development of the vision, and you've kept us on track, which has been admirable and we're really thankful for. So well done. Thank you, Katie.
Thank you.
Thank you, Katie.
Beth, I think you're also now going to share some of the experience of being supporting of your brother's situation.
Yes, thank you. I'd like to introduce you to my brother, who is Ian on the right. Our Ian is a miracle. As a baby, I wasn't born, but he was eating. When he wasn't eating, he was sleeping, and when he wasn't sleeping, he was crying. And at the 2.5-year-old review, my mum was told straight off from the doctor doing it that this child is handicapped. He had a brain scan that showed that his brain was 2/3 in and 1/3 instead of half and half. And the doctors said that if they hadn't seen the child, that they would think that he would be unable to speak or walk. And our Ian is a miracle because he can do both. Ian was finally diagnosed with Asperger syndrome, which is a form of autism and associated learning difficulties. He was 15 when he got this diagnosis, and that was 30 years ago. 20 years ago, Ian moved out of the family home and he went to live in the council house and was placed with a lad with complex needs with the care provided by the council. The care provided was meant to be 2 support workers, so they had 1 each. It didn't take long for the support provider to cut it down to 1 support worker between the 2 of them. The chap that he lived with was louder, often locked Ian out of his own house, demanded that the walls be painted in red, which Ian hates. They got 2 cats, 1 each, which Ian didn't want. And Ian's voice was not heard or valued. Whilst his family spoke up for him, making complaints and suggestions, every time, after about 3 months, it would all return to how it used to be, and the problems would return. The council were paying good money for my brother to be miserable, anxious, unheard, devalued, unsupported, and not living a good life. Support was done to Ian, and he couldn't have felt less supported. After 7 years, he said he'd had enough and wanted to move out. At the same time, I heard about a pilot scheme that was called In Control, which was appealing to us, as for years we'd had no control, no say, no choice whatsoever. In Control was a scheme where we were paid the money that the council paid for Ian's support, and it allowed us, his family, to make decisions with Ian about what he wanted out of life. And this is how we got involved with direct payments. Our Ian is a miracle. We never thought he would live alone. But in 2009, we got him a rented place where he had the choice of who was going to provide the care and support for him. However, you have to be careful what you wish for. We had absolutely no idea how to put out job adverts, do interviews, hire, recruit, manage staff. We had no training and we had limited support from a government in austerity. Over the next 10 years, Ian had people who failed to turn up at shifts without warning. He had staff who ended up being sectioned the day I had to sack them. He had warnings of a legal battle about payments for hours not worked. We had staff who stole money off him using his card in an ATM. We had staff who took him to their own house so that they could do their ironing while he watched the television. We had staff who ignored his views and continued to drink foul-smelling herbal tea. Now, that last one might sound like the smallest of misdemeanors, but because Ian has hypersensitivity to smells, he could not forgive that person. In managing all of this, I had phone calls at 9 o'clock on a Friday night accusing me of not paying the staff enough. I had phone calls when I was in the supermarket in the chiller aisle doing my weekly shop, trying to explain that Ian did have Asperger syndrome and it wasn't something that could be cured by a diet. I had calls waking me up at 6 o'clock in the morning asking if that they couldn't turn up for the shift and could I go and sort him out today, 4 times in 1 week. Ian would phone asking whether people were coming and I didn't know what to say. I had Ian not knowing where his belongings had gone. I saw bank statements coming with money coming out of his account. I had staff holding me to ransom because they knew that I couldn't get anyone else in to do the morning shift, so they were the ones calling the shots. Then I received letters from the council saying I had made unauthorised expenditure. Talk about a kick in the teeth. We were stuck knowing that Ian wasn't happy and we didn't know what to do. Me and my family spent a decade living with that guilt that Ian wasn't happy and it was our responsibility. To try and help with Ian's mental health, I volunteered to chauffeur him to places he wanted to go to once a month. His happy place is anywhere that has vehicles with wings or wheels that are vintage. But because the direct payment hours were allocated on a daily basis and weren't flexible, I had to pay for the staff whose hours were allocated whether they did them or not, because otherwise the money would be taken off us as unspent funds. I had to keep the records and manage his staff while living over 200 miles away, and I had to attend meetings in the office to explain the spending in the council. We had a constant worry that the money would be taken off us, and we lived in fear that Ian would be left without support, so we kept our heads down and said nothing. After each audit, the annual budget was reduced, but Ian's needs had not changed. I had a fear that if the money matters got wrong, I would be taken to jail for fraud with the way that the letters were written. And if I wasn't taken to jail for that, then I would end up in an employment tribunal for doing something wrong with the staff that I didn't know how to manage. I moved back to Shrewsbury to make sure I was around because my mum wasn't getting any younger and couldn't do it anymore. When I went through this talk with my mum, she said, "We were living through it and thinking this isn't right, but what can you do?" Then I received an invite in the post from the council asking for feedback on how it was going, to go to a workshop. Feedback, I thought, I'll give you some feedback. I've explained earlier about the workshops, during which I explained the situation and my worries for Ian, and I got the help I needed with the right people to provide the right support for Ian. And they are people who understand him, they get it. Then COVID hit. The work that we had done in the workshop and Mend the Gap had identified that direct payments need to be more creative and flexible, and COVID certainly tested that. Because of COVID, Ian wasn't able to go to his walking football sessions anymore, and early on in COVID, he had a bad experience with the bus driver not recognising the mask exempt cards, which is like the one he was seeing on the lanyard. So that knocked out bus travel for him. He was suddenly isolated and couldn't go anywhere. This was the first test to see if the changes were real from the council. We applied for and were accepted to be able to use the direct payment to buy him a tricycle. The tricycle has given him an independence that he never had before. Then the world started opening up again. As I said before, Ian's happy place is anywhere with wings or wheels. We were just about able to juggle the hours to fit in going for a day trip out with his support workers. He went to car festivals, air shows and train trips, which were back on. And Ian was so happy that he could go with his support workers, and really happy that I was really happy that I didn't have to use my free time to take him away as chauffeur. Especially because in the air shows, even with the loud noises going overhead, I used to fall asleep because I was so knackered. This was the first time I'd not have to do the driving myself. Ian got his life for the first time and I got my life back too. Because of the direct payment flexibility, he was able to attend a motorbike show recently, and this is where he met the chap in the picture that you might recognise off the television for renovating motorbikes. Henry Cole is literally Ian's hero, because we have my dad's 1950s motorbike in the garage that one day we'll do up and take to shows. So this is photo of Ian looking at his very happiest. This photo moment was made possible by using direct payments in a flexible and creative way for Ian to have choice and to have his voice heard and to be living his best life, doing the things he wants to do and the things he enjoys. It's taken until he was 44 years old, but we finally have got there. Our Ian is our miracle. However, there are a few issues still. As we heard earlier with Bishop's Castle, there's a nationwide shortage of support workers and carers, and Shropshire is feeling this shortage acutely. At the moment, I can't get anyone to do the morning shift to make sure he's up and awake and leaves in time to get to his volunteer work, so I've been doing this for the last 3 weeks. Over the last 2 months, Ian hasn't had any support at all provided for 2 or 3 days a week due to the lack of staff availability, which COVID isn't helping. However, there is an improvement to the system, and that's where if family members are called in the event to help with cancelled support, that's now costed, so at least our input feels valued rather than just assumed that it will happen. And it is getting better, because next rota has only 2 days without support being provided, and I have today off work where I can phone round and see who's available to cover the mornings. It's my experience that direct payments can work incredibly well, giving recipients choice and agency in their own lives, but the system only works if there are carers and support workers there who are available to provide the support to those who need it. Thank you.
Thank you, Beth. That was really insightful. Thank you for sharing that with us. So, oh, Gary.
Yeah, sorry, I was going to say, there are, just to put into context, we are measured as a local authority as to how many direct payments that we provide to adults in Shropshire. And we've, in trying to sort of help our performance, we provide a local report as well, which looks at individual service funds, which is a hybrid of both a direct payment effectively and the commission services that the council provide. So it enables the individual to liaise with the provider to procure the care when they want it and how they want it, but it's not a direct payment. We do very well with ISFs in Shropshire in promoting people's control of when the care is provided, but it isn't, unfortunately, considered to be a direct payment. We've now got an interim director who's very much on board with this, and looking at how we can develop the service we provide more broadly and more widely, and referred to it on here as a self-directed engine room, but it is literally working together with both experts by experience, our practitioners, our managers, in trying to create or solutions to enhance or increase the take-up of direct payments.
I think this last slide was illustrating that we're on a journey and we're not there, and we know that we've got a lot more work to do and to achieve. As we've heard, the situation with recruitment and retention is a continued challenge, and so we're looking at how we can use some of the national software platforms like Indeed, but also looking at a local PA pool, but recognising in order to have that sort of notice board pool facility, that does need a resource. It isn't just something you can pin things up on. It needs looking at and resourcing and checking the right people are actually coming forward and safe, in effect. Employment support, we've had lots of conversations and we're continuing to look at the various options that are available, be that employment support through insurance providers or some of the indirect support systems that can be brought in. Peer support, we did start off with people using direct payments, having peer support groups. COVID actually put a bit of a challenge to that, but we're back to looking at that again, because you can use Teams and we can actually start going forward. Ongoing education is one of the key developments, not only for people who are coming to us for assessment, so that we start actually talking to the people who may be able to benefit from having a direct payment, but also to change the culture and to support our practitioners to recognise and see the incredible difference that having a direct payment can make to people. The website's up and running, but of course a website doesn't stop with just being set up. It has to be kept up to date, it has to be refreshed, things have to be accurate on that, so that's an ongoing situation. The health system has personal health budgets, and there's a couple of people like our direct payment leads who are helping to lead and develop the personal health budget agenda, and we've actually started to work together and to share information and some of the approaches that have come forward. And of course it's an all age, we are now a people directorate, and we're keen that it isn't an adult only approach, but it's an all age approach.
And finally, this is the opportunity to answer or any questions that you may have. And thank you very much for listening to us.
Thank you guys and all the team who presented there. It's fascinating to see how direct payments have evolved since I think I was involved 8 years ago or something as portfolio holder then. It's nice to see that it's evolved. I think the talk then was about evolution, not revolution. But it's nice to see that you know, especially Beth telling the story of her brother there, how much that's impacted in such a positive way. Tanya, is there anything you want to add to the mix before we go to questions?
No, I don't think so, Steve. Thank you very much, team. It's great to see the journey, and we are on a journey, and you've got some great foundations in place now, but I'm sure committee members will have some questions they will want to ask.
Okay, Kate Halliday, first question.
Yeah, first I'd like to thank everybody who gave us that presentation. That's one of the best presentations I've experienced in this committee. And I think part of the reason for that is the move towards co-production. And I think, you know, I think it's a great move for the council, but clearly, you know, the impact that it is having on people using services. And I'd like to say especially thank you, Katie and Beth, for giving this presentation, because I think it brings it to life. It brings to light. So often we have talks from people who deliver services, and you've really kind of brought to light exactly what is involved in actually receiving these services. It really does sound like there has been a big move towards improving the quality of these services, and I do appreciate you're in the really early. We're in the kind of probably in the fairly early stages of this, and we've had a pandemic going on in the middle of it all. So I've got a couple of questions really. Firstly, have you experienced, or could you say a little bit more about how have you experienced a greater uptake as a result of this, or are you still in the quality stage? Improving quality stage. And then my other question is around, Beth, you gave a really good, difficult account of what it's like to be an employer, and that clearly, you know, your brother's experienced great improvements in his care, but that it sounds like it's quite a challenge to be an employer. And so what is being done to support people who are moving into becoming employers and perhaps learning from some of the experiences that Beth outlined?
Okay, I think we'll just take another question from Heather and we can get a response from the team.
I think this is a fantastic presentation. I think it should have gone to all members, quite frankly. I'm not sure it should just have come to us. It's a much bigger issue, and the stories that I've heard are exactly those stories that I have experienced on the ground, and some horrendous things happen to people across my division. And that will be true for all 74 of us. We will have had those. So I think it should have been a training session, quite frankly. I think also I recognise one of the ladies in one of the workshop session, who actually has caused me lots of casework because of exactly the things that you were bringing up. So the proof of the pudding will be in how much complaint I now get from that resident. So I will be asking her, and I'm sure Gary can work out who it is, because we have been to see you a number of times. But scrutiny isn't about information items. It's useful that we know about it. Scrutiny is about actually adding value and making a difference for our residents. So what can we do as a committee to actually make a difference to what you're doing, so that we have some outcomes that are useful as a scrutiny committee, but actually it helps all of our residents and you to do the very valuable work you're doing?
Okay, over to Gary and again.
Okay, shall we start with the first question, I think, which was about uptake? So you asked us whether or not the uptake had increased and the impact that the pandemic had on direct payments. In some ways, because of the difficulty for our provider market, the agencies, we've actually seen quite a large increase in interest for direct payments because there aren't as many agency providers available able to produce the packages. So in some respects, although that's not why we would want to see direct payments increase, it certainly has had an influence. So we've seen a lot more inquiries. Direct payments do take a lot longer to set up. There's a lot more conversation, a lot more working together and looking at the options than simply contracting with an agency provider. You know, the employment of PAs is not a straightforward answer. Direct payments, though, can also be used to employ an agency. So it doesn't have to be a direct payment to employ a PA. And some of the people who receive direct payments have a mixture, have hybrid, will employ some agencies and will also employ their own PAs. The pandemic actually also enabled a number of people to have, I think the practitioners had the opportunity to think a lot more flexibly and outside of the box. So there are certainly stories of people who received a direct payment to provide things or buy things or purchase things that probably previously we would not have necessarily have considered or been asked about. So there are examples of people, because they were at home, because they weren't necessarily able to go out to day centres or shops when we had those lockdowns, actually had provisions for things like a swing. We actually even had one gentleman who received a hot tub in order to support him. So there was a lot more flexible conversations taking place as to the nature of the different things that could be thought about as a direct payment to meet the eligible assessed needs that had been identified. Beth, do you want to answer the bit of the next question that I think may be aimed at you a little bit about the support that you need as a employer?
Yes, thank you. I think the co-production doesn't just help the council improve the services, but for me it was life-changing, as I've sort of tried to explain, to be involved, just to see what's happening on the other side of the brick wall and to be able to provide that different perspective. So you feel like not only are you learning something, but you're contributing. So I gained a greater understanding of what it was to have a PA. I didn't even know the difference between an authorised person and a nominated person. I mean, I'd still have to look it up now, but I know where to look. And so this is where it's the change has been massive for me in terms of, it's a bit like with the Wizard of Oz, you know, you think that there's this big all-powerful God behind the Iron Curtain, but actually it's just another person who's trying to do their best. So I think that from that perspective, that's what I've gained from being in co-production. From the this is where with the recruitment and the employment, that's all still ongoing work, and Katie and I are both and others are still putting into that to say, you know, these are the obstacles that stop people from becoming an employee. You know, what happens on maternity leave? What happens if someone gets COVID? What happens? What do I have to do as an employer? And we're providing those questions for then the council to go, okay, well, what does happen? Rather than just being airy-fairy going, oh, yes, you have a plan B. What does that mean? If I'm on holiday or I've got COVID or whatever, what does that actually mean? So that's the work in progress that's still going on at the moment, as well as there being a bit of a drought for the people who are engaged in actually wanting to do the jobs in the first place. Katie, have you got anything you'd like to add on that?
Oh, you're muted, Katie. Somebody had to do it between the four of us.
I know, and it was me, wasn't it? Typical. I think Beth near enough put it smack on, really. I've got a supported account that my mum manages, so very much like the position Beth's in. And one of the reasons that I've got it as what they refer to as a third-party supported account, which is it's managed my timesheets and the timesheets, the tax stuff, national insurance, that's all managed externally, even from my mum. and that was due to a fear of, oh my gosh, how do I manage all this paperwork? And even for my mum, you know, this is a lot of paperwork to try and manage, and that's still a fear I do have. And, you know, as Beth's saying, you know, it's still a fear as an employer. And I've said all along that I know we've got it right when I will sit there and say, I don't need that third party support account. I'm happy to take it over, or say to mum, here you go, you can take it, but you know, you can do the hard work now, you know, and I know that's when we've got it right. So, you know, there is a lot of work involved with it.
Can I just add something to that? Sorry, because just picking up on Katie's point there with other people sitting with the management of accounts, we've looked at all the people who receive direct payments to understand what a contingency is as well, because as much as we're all reliant on an individual to manage a person's account, or the individual themselves or a representative, whatever, that's great as long as it's working for that period, and hopefully nothing happens. But we've had a few cases where obviously the individual operating the account has either been hospitalised or not unable to do any longer, and so we're looking at how can we address that, because what we don't want to do is jeopardise or compromise the direct payment or the continuation of the direct payment for that individual. So how can we address that? And we are looking more widely at trying to find external bodies that can help and support in this way. So we're not in a position when we have to start looking at a different type of care, because the direct payments for so many people, and the reason they're kind of so successful is because you're in control of it. You're able to kind of hit in when they come in, the times, and we want to try and maintain that. But there is a challenge when the individual that is responsible is compromised in some way, whether it be, say, through hospitalisation or through illness, or just no longer wishes to do it. So just saying. Just
to add to that as well, can I just raise how wonderful Shropshire Carers are as an organisation? They are, I phoned them because of a direct payment newsletter, and there was some information in there, and I thought, oh, that's interesting, I'll see who they are. And I spoke to this wonderful woman who she taught me about having a care plan. So if I go into hospital, people know I'm a carer and know that I've got responsibilities for someone, and know that there's going to be a gap if I'm not available. But also there's a pet care plan for Ian. So if he goes into hospital, knowing to call him Ian and not Robert, which is what is on his birth certificate, because he will just ignore people, and it's not a good start to getting any sort of treatment. But there's different things like that. The carers in the Shropshire Care organisation are absolutely brilliant, and they have so much information and wealth of experience in this, and they've set up these things just to make those difficult things in life a little bit less difficult. So I'd really commend that anyone who has a person who is talking to them about being a carer or about having responsibilities. I didn't, before reading or speaking to this lady, I didn't actually think of myself as being a carer, because it was just my brother, and that's what you do. So knowing that there's this stuff and this support in place for you is a real help, and it's just a phone line to just go, you know what, I'm feeling a bit crap today because XYZ, and it's because I have to have all these responsibilities on top of my day job, on top of this, on top of that, and then my budgie died, and now that's the end of it. You know, it's having that support line and that sort of knowing that people are there for you and that they understand what you're going through, and I think that's really important as well.
Thank you for that, Beth. I think that sums up what we're all learning about very, very quickly in the last 3/4 of an hour, whatever it's been. It's been absolutely insightful into the world of direct payments, and I take the hat off to people like Beth and Katie who are working within the system for people they love, and doing the best that they can in difficult circumstances. So well done to both of you. And can I thank you both as well as Carol and Gavin. Sorry.
Can we find out how we make a difference to this, please? Because that's what we should be here for. And how we value added. I asked that question.
Yeah, I'm just looking at the clock.
I know I've got to go, but it's a valuable question.
It is a valuable question, and I think that we all acknowledge, as I said, we're on a journey. We're starting to listen, and some of the things and the points that you've raised there are very pertinent. We recognise that some people need more support in order to be able to. People like Beth need that support in order to run her brother's account, and so currently we're looking at what other opportunities are out there. We've looked at the PA pool, we know and we do, and we're committed to that, but we will need to have some additional resources in order to make that work. We've looked at what other national organisations can provide us when it comes to employment support. So some of the people that we're working with say they'd like to have a physical person visiting them when they're interviewing, for instance. Well, that's not something that the current social work practitioners would be able to resource. It just wouldn't be possible. So we're looking at where that sort of support could be sourced and what resource we would need in order to do that. So I think it's that next stage that we can see where there is a need, but some of those things in order to be able to provide are going to need a resource to do that.
Okay, thank you, Carol. Gerald.
Yeah.
Mr.
My question is, can members of the family become employed by on this scheme or not?
Sorry, I missed the question. Can members of the
Family members, can they get part of this grant or not?
No, the direct payments is actually based with legislation, and it's very clear that people who live in the same household cannot have a direct payment unless there's an exceptional circumstance. So during COVID, when some of the care situations like maybe day opportunities or things that some individuals would normally have been doing, swimming or going wherever, were no longer available. So we treated that as an exceptional circumstance. In that situation, for a short period of time, some family members who lived in the same household were provided a direct payment in order to continue with the support, but it was very short term because that's not how that wouldn't have come within the legislation. Family members who do not live in the same household certainly can and are funded as a direct payment and do become certain family members' PAs. Although we also always do have a very open and honest conversation with the individual employing the family member and the family member, because with that just does come complexities and comes challenges. You know, if it's your mum, dad, brother, sister who's your PA, at what point are you able to challenge them if you want to go out to the park but they don't actually feel like it that day? But because it's your mum, dad, brother, sister, friend, you might not feel as comfortable to challenge and say, no, I'm employing you and I want to go to the park today.
That's understandable.
So they do have to have other conversations when that is set up.
That's understandable, but I'm sure if you employ family members, you get better value for money.
You can do, but as I said, it is all, I mean, A, there's a tax issue for some people, B, it's not legislative allowed anyway, and C, as I said, sometimes you have to have a different person you're employing, it's your employee, so you don't want to jeopardise the family relationship and the support that's offered. Obviously, there's also carers allowance, which is paid to some carers who provide over 35 hours support in a week.
I think as well, just to add to that, whenever I've had conversations with Ian's PAs, and he talks a lot more to them than he will talk to me, because he doesn't want to upset me, he doesn't want to worry me or anything like that. So I think that there's that in there as well.
Okay, thank you. I'm going to let Tanya wrap up.
Thank you, Chair. So just reflect on the added value of this committee, and I've got two suggestions. One is around the numbers for direct payments is low in Shropshire, one of the lowest in the West Midlands. So whilst it's great work that we're doing, we are on a journey with a great vision, a great policy and a great team around us. But the added value the committee could put in is around what the difference is actually making in 6 months, in 12 months' time. And secondly, we've heard throughout the whole morning is around recruitment and retention of both personal assistants and domiciliary care workers, and I would suggest that the committee might want to consider how does Shropshire Council support people who think about being a personal assistant, how do we recruit them, how do we make it attractive, and how do we retain people to work in that kind of sector.
Key workers?
dwellings.
Yeah.
All of those things, which hopefully we can build in with the NHS stuff as well, because it's just as important.
And then finally, I think we do need to have a wider member briefing and your inherent direct payments. That would be a great suggestion for January now, so to Christmas.
Yeah, I'm more than happy to arrange that if the committee like me to do so.
Absolutely. I see Simon James portfolio holder with his hand up. You have to be quick, Simon.
Yeah, just a quick comment, because I've got another meeting I've got to go to with Rachel actually. But I just wanted to say thank you to the team for the presentation, in particular to Katie and Beth, and Beth, particularly powerful presentation that you made there. I just wanted to thank you and look forward to working closely with you. Thank you.
Thank you. I think you echo everyone in the room as well by saying that. So thank you. No doubt we will be touching base again on screen or in the meetings personally. But thank you everyone for presenting.
Thank you. Thank you for your time.
Thank you. Thank you.
Thank you.
Okay, we're going to move on with the agenda. I'm passing over to Daniel for item 8 and 9.
Thank you very much, Chair. You should have a copy of the work programme in your pack. I'm proposing a few changes since this was published, from just discussions with officers on how best to timetable this work and what's happened in this meeting today. I'm going to propose that our briefing and joint commissioning and our item on joint commissioning is postponed until the briefing until February and the item until March. This should just give officers or the new director more time to prepare that work, so she's got something more meaningful and substantial to present to you. That would sort of free up a little bit more space. But for the January meeting, which is looking rather packed at the moment, you've also asked for an additional meeting in early January to look at the closure of Bishop Castle Community Hospital. What I propose to do is for the committee to have an informal working group to prepare its lines of inquiry and the information that it requires in advance of that meeting. So if you're happy to do that, I can organise that before Christmas and recruit from within the group. We don't have a date yet for that meeting. I know a date is the 10th of January was mooted, but I'm not sure that clashes with everyone. Everyone is free for that meeting at the moment. So if you just leave that with us for another week or two, and we will propose a date for that going forward.
So are we happy that's a plan of action?
Yeah, absolutely. I've really got to go, but there are. What I'm concerned about is what's going through Parliament, and I've raised it before, over social care and funding and so on, and the impacts on us. So at some point we need to build that in properly, because looking through the work plan, it doesn't actually seem to be there.
Yeah. There was something else actually as well I forgot to mention, and that's normally this committee looks at the council's winter plan going forward, and I would propose that we look at that sooner rather than later. So as well as looking at the issues arising from today's meeting, that we also bring the winter plan to our first meeting in January, if the committee is okay with that. Indeed.
Great, thank you.
And Daniel, item 8, the joint hospital.
Yes. Yes, just one more point actually. I think this should be fairly straightforward. Obviously, we need, with the departure or the ascendancy of Councillor Jones to Cabinet, we have a vacancy for the Joint Health Overview Scrutiny Committee. The membership or the candidacy for this members is limited to members of the Conservative group. I can see most of you here at the moment, so I would like a nomination, please, for somebody to be a member of the Joint Health Committee.
Can I propose Steve, the chairman, please?
Marvellous. Would anyone like to second that, please?
Sorry?
Yeah, marvellous. Thank you. Yes. Would anyone like to second that? Thank you, Nick. Any other nominations? Marvellous. Then I do believe then that's carried. Thank you.
Chairman, can I also request, or Daniel, that we have regular notes, like minutes of that meeting of the joint, because it's an important committee and it aligns very much with us. It's 8 years ago now since we started talking about the reconfiguration of the hospital. That's been going on for 8 years. We know very little about it now. Just don't get any feedback much on it. And I wondered that, I looked at for the minutes that you sent out, and there's minutes of the joint committee there, and they're very, very handy. I've not seen those before on this committee, and I'd like to, can you continue them?
Yeah, of course, Councillor Dakey, I'll do that for you.
Okay, so with that, I think that concludes today's meeting. So thank you everybody. I'll see you in January, if not before.
Thank you.